what we're hearing here is there's a lot of advances in our understanding of IBS pathophysiology. We're seeing advances in the microbiome in particular as at least one mechanism potentially along a causal pathway for the whatever underlying principal cause of IBS is, if there is one. Or is this really about segmenting a group of people, as we've also talked about today, that presents in a common fashion, but has a very wide variety, a dazzlingly wide variety of comorbidities and underlying potential mechanisms, both neuropsychological, mechanical, microbiome, and so on. So, we know that the GI tract can only present itself to us symptomatically in a few archetypal ways. It turns out there are only 8 ways that the GI tract produces symptoms. And this is research that we did for the NIH, for the NIH Promise, which is actually in our My GI Health app. You can measure your scores across those 8 components of GI health. So pretty much you have abdominal pain, or you have bloating, or you have diarrhea, or you have constipation, or you have nausea, vomiting, or you have incontinence, and you're pretty much out of principal symptoms. So the point here is, IBS, of course, attempts as best as it can to distinguish organic disease from, traditional organic disease from what we have traditionally called functional disease. But we also know there's a whole wide variety of under or undiagnosed mechanisms. How often do we actually think about the mesentery and the anatomy of the mesenteric root, right? I mean, we talk about Ehlers-Danlos, but every organ system has evolved differentially in different people. Just start with that. There's so many biomarkers that we could be focusing on to segment patients more precisely and start figuring out what the underlying etiology is that's driving their symptoms. And then ultimately, as we've been saying, it's important to become equipped in the clinic, and not just with theory, but with a set of best practice treatments